and welcome to our last grand rounds of the academic year. I'm Dr. Kim Williams, Chair of Medicine here at University of Louisville, and it's my pleasure this morning to introduce our introducer for Dr. Abigail Chan, who will be giving a wonderful lecture on rising trends in early onset of GI cancers. And her introducer will be our own Dr. Elizabeth Riley. Dr. Riley is from the University of Louisville for medical school. She did her residency and fellowship at Harvard Medical School's Beth Israel Deaconess Medical Center. She is currently professor of medicine here, and she is the deputy director of the health affairs for UofL Health Brown Cancer Center and section chief in medical oncology and benign hematology. And she directs our breast cancer multidisciplinary clinic. And with that, Dr. Riley, please take it away for Dr. Chan.
Thanks, Dr. Williams. It's my honor to introduce Dr. Chan. She is what I like to call homegrown success story. So she was a previous fellow within our division where she won Best Fellow Award. She came to us by way of Baltimore and where she did her residency at Sinai Hospital. And what we're really lucky to have Dr. Chan is she has an increasing interest in young onset GI cancers. And as many of you may know, the incidence and age at which we're seeing diagnoses is getting earlier and earlier, not only in GI cancers, but in a lot of malignancies. So really understanding why this is happening is increasingly important for our patient population. So with that, I give you Dr. Chan.
Hi, everyone. Good morning. Thank you for the opportunity to give this Grand Rounds talk. So as everyone said, my name is Abigail Chan. I am an assistant professor of medicine at the Division of Medical Oncology and Hematology. I mostly see GI cancer patients as well as some benign heme patients. And today's talk is entitled really The Rising Trends in Early Onset GI Cancers. Sorry, my slides are not moving forward. I don't really have any disclosures. Today's outline of the talk will be a review of the trends of GI cancers in the young, and then we'll put some focus on colorectal cancer, which will really take up a bulk of the talk because that's where most of the data has surfaced over the recent years. We'll go into the risks and protective factors that have been identified, current screening guidelines and modalities, signs and symptoms, or rather red flag symptoms to watch out for in our own clinics, molecular characteristics or differences of early onset versus late onset CRC, treatment considerations and unique challenges in this patient population, young onset CRC program at the Brown Cancer Center, and a little bit of focus on esophageal, gastric, and pancreatobiliary cancers. So just to start off, this is the latest year data. So the image to the left just gives you the top 10 most common types of cancers. GI cancers being colorectal and pancreatic are one of the more common ones. So fourth spot is colorectal, 10th is pancreatic, where you expect about 150,000 cases to be diagnosed in 2024 for colorectal and 66,000 for pancreatic. If you take a look at the image to the right, it also gives you an idea of the cancer-related mortality with GI cancers, so CRC, pancreatic, hepatobiliary cancers, which are unfortunately less common, but also proving to be quite deadly, are in the top 10 for both males and females. So this is for the general population. Looking into colorectal cancer by itself, overall, when you compare from the 1960s to 2019 for incidence, and then from even the 1930s to 2020 for mortality, you can see that there is overall a trending, the trend actually is decreasing, probably owing to the fact that we've gotten better in how we do our colonoscopies. So when you compare the number of colonoscopies that were done in 2000, there were about 20% in those who qualify, or those greater than 50 would get colonoscopies. By the time we, in 2018, that has rose to 61%. So a large part of this decreasing incidence and mortality is probably because colonoscopies are doing much better. We're doing so much better with colonoscopies, and you kind of stop the adenomas from developing into carcinomas. The problem is really when we take a look at the incidence of CRC and divide it into subgroups by age and stage. And even just by looking at these two graphs on your right, you can see that with those who are 65 and above, it's somewhat trending down, but those who are 20 to 49 years old, the trends are going up. And if you take a look at even further, regional disease is much more common than those with localized disease. It's estimated that there's about a 1.1% increase per year from 2006 to 2015 in diagnosing colorectal cancer in the young. A large part of this is really more so from rectal cancer rather than colon cancer, 1.7 versus 0.7. So again, taking a look at the image to the right, when you just compare those who are 65 and above versus those who are 20 to 49, the one that is kind of yellow and green, those represent your distal colon and rectum and rectus sigmoid junction primaries, and the one in purple or proximal. So in 20 to 49, you have more distal disease or distal colonic rectal disease. And then if you go to 65 and above, you have more proximal tumors. It's estimated too that by 2030, 10% of all colon cancers and 22% of all rectal cancers in the United States are to be diagnosed in those less than 50. And I'm just quoting US data, but this is actually being seen worldwide, especially in those industrialized countries. This is another graph, and we'll see a lot of graphs today. This image basically indicate somewhat of a birth cohort effect, wherein patients who are born in your 1950s, 1960s, and you compared it to those patients or general population who are born in 1990s, you can see that there is a stark increase by generations. So this suggests that there might be some shared risk factors common across the generations that have contributed to the increased risk, be it changes in obesity, sedentary lifestyle, or diets, use of antibiotics, and things like that. This is looking at the number of deaths and mortalities. The one figure on the left is for men, and the one on the right is for females. So in young men, the one in light blue is basically the one for colorectal. So in young men, colorectal cancer is now the #1 cause of cancer-related deaths. CRC, when you compared it to lung cancer, has caused 2 times more deaths. In females, breast cancer is still #1 in terms of cause of death, colorectal at #2. But again, it's estimated that in 2030, colorectal cancer will be the #1 cause of cancer-related deaths in both males and females in the young. And I forgot to say that when we refer to someone as young, it's usually just less than 50 years old, and that is just an arbitrary number that everyone uses. Shifting a little bit of focus to esophageal and gastric cancer, overall, we can see that gastric and esophageal cancer incidence is declining in the United States, partly due to smoking cessation, improvements in the way that we have managed reflux disease, increased treatment of H. pylori. However, its incidence is increasing in the young as well, more so in gastric rather than esophageal. It's disproportionately affecting Black, Hispanic, and Asian populations, and there's a high proportion of males than females getting diagnosed, and we'll talk about risk factors and things like that later. As for pancreatic cancer, similar story, that we can see that those in the young, especially those in 20 to 49 years old, have a higher annual increase, and the trend gets less as we grow older. Now it's affecting more women and Black population. Even pancreatic neuroendocrine tumor is actually also on the rise. This is just another graph that looks at the early onset CRC. We've talked a little bit about the colorectal, stomach, and pancreas, which are the more common ones. But really, if you take a look at endothelial cancers, that's also on the rise. Not so much for liver, esophagus, intrahepatic bile duct, or biliary cancers are also on the rise. Same goes with gallbladder. So now we'll go and focus on colorectal cancer, which is really going to be taking up a bulk of it. This diagram is from a NEJM article by Dr. Sinecrope. If you have some time and want to read about early onset CRC, his article is actually very good. It's short, straight to the point, lots of images, so it's pretty good, pretty easy read altogether. So we'll talk about kind of exposures from infancy to adulthood and how they might have and what risk factors have caused increased CRC. Just to start off with, we always think that in early onset, there's probably some sort of a family history related to it or some sort of pathogenic germline variant that could have caused CRC. But really, there's only about a quarter of cases that have some underlying germline mutation. 75% or 3/4 of the cases are still pretty much sporadic. When you compare it to CRC in all ages, 10 to 15% have pathogenic germline variants, 85 to 90% have sporadic cases still. So even if there's a higher prevalence in the young to have pathogenic germline mutations or variants, we still cannot just chalk it up to all genetics. The NCCN guidelines, or the National Comprehensive Cancer Network, which makes up a lot of our guidelines, not just for treating the cancer itself, but also gives us some screening recommendations, now recommend genetic risk counseling and evaluation for patients with early onset CRC. So we don't really follow Bethesda or Amsterdam criteria as much as we did learn through med school. It's really just anyone who is less than 50 would qualify for it. Things that need to be tested at the very least would be tests for Lynch syndrome, which is basically a deficiency in your mismatch repair proteins, which are your MLH1, MSH2, MSH6, PMS2, and EpCAM. APC gene mutation for familial adenomatous polyposis, MUTYH associated polyposis, your BMPR1, SMAD4 for juvenile polyposis syndrome, P10 for Cowden, and STK11 for Peutz-Jeghers, and maybe TP53 for Leigh-Fraumeni as well. So looking at risk factors, so I got these risk factors really from a meta-analysis that included about 30 studies, and they wanted to take a look at what risk factors were associated for the development of early onset CRC. So they saw that increased risk if you were male, Caucasian, really if you have a family history wherein your odds ratio was 5.9. If you have evidence of inflammatory bowel disease, which makes sense because you have ongoing inflammation, which then gives you kind of a background to get carcinoma and hereditary syndromes that we have talked about. Obesity seems like a big and recurring theme in different forms of and markers of obesity as well, not just in CRC, but later on we'll talk about pancreatic biliary as well. They've defined obesity as BMI of greater than 30. Liu et al. Had looked into it that if you've had about a 40-kilogram weight gain since 18 years old, you have a higher risk to develop CRC. Abdominal obesity, high triglycerides, and metabolic syndrome were also risk factors that were identified. Hypertension and diabetes by themselves were not, but I guess with a combination of all of it in metabolic syndrome, they were able to get that correlate. Western diet patterns, which has a lot of red meat consumption and processed meat consumption, plays a big picture. Western diet, I guess, in a way promotes a different microbiome with unfavorable microbes causing mucosal inflammation, then increases your risk for colorectal neoplasia. There's also a paper that I had read that's Western diets do have a lot more sulfur metabolizing bacteria that's mixed with it, which tends to be more genotoxic, causing cancer. You can also have sugar sweetened beverages, and they've defined it really as more than 2 beverages in a day increases your risk. It's also pretty interesting that when they looked at breastfed individuals, they saw that there was an increased risk in patients who were breastfed, and it's actually dose dependent. So the longer duration you were breastfed, the higher the risk. Smoking defined as greater than 20 pack years smoking history, alcohol use of more than 14 alcoholic drinks per week, and sedentary lifestyle also plays a role. The sedentary lifestyle defined as more than 14 hours a week of sedentary TV viewing time. Antibiotics as risk factors are a little bit controversial. There's some studies that show that there is an increase with use of antibiotics, but there's some studies that also contradict it. There was a study done in the UK that showed that if you have antibiotics used, especially penicillin use, that you could have an increased risk of colon cancer, but then maybe protective in rectal. So we don't really know how we stand with antibiotic use. And again, gut microbes, microbiome changes wherein they interact with the host immune system and influence anti-tumor immune response is now being a very thing that we try to look at. We saw that in colorectal cancer, there seems to be an over-colonization of Firmicutes, enterotoxigenic Bacteroides fragilis, and Fusobacterium nucleatum seen in the subset of patients. But really, in summary, just to kind of sum up the risk factor slide, there's really no one risk factor that we know can cause early onset CRC. Highest interest seems to be determining the factors which influence microbiome and trying to figure out when is it that we have to intervene. Do we intervene when they're in childhood? Do we intervene when they're an adolescent, or is this something that as an adult we can still reverse? So obviously there's still a lot that we don't know. There's still a lot that we hope to know in the future, just so we know when do we need to educate patients and when do we need to change ourselves. They did recognize some protective factors, vitamin D as a protective factor, and diet high in vegetables, fruits, having a prudent diet and not overeating, fish, consumption of beta carotene, vitamin C, vitamin E, folic acid, and intake of whole grains are protective factors. The question too is it potentially reversible? So this article came out at JAMA Oncology earlier in the year. They looked at patients who were drug naive with type 2 diabetes, with and without obesity or being overweight as risk factors. And they looked at patients getting GLP-1 receptor agonists. And what they saw that patients who were taking GLP-1 receptor agonists had a 44% risk of developing colon cancer than those who took insulin, and about a 25% lower risk than those who took metformin. In patients who were obese or overweight, that effect seems to even be more pronounced, wherein you had a 50% risk in lower risk in those who were taking insulin, and about a 42% risk in those who take metformin. So there is some suggestion that it might be reversible. These are all adults who came into the study, but we don't know yet. Just talking about screening, we know that, as kind of probably been told multiple times, is that the US TSTF now recommends colorectal cancer screening at 45 years old instead of the previous 50. Now, this screening recommendation is really only applicable to those with standard risk, does not apply to patients who have high risk factors or a previous abnormal colonoscopy. So if they've had multiple adenomatous polyps, serrated or hematomatous polyps, they don't qualify for this. They need to be done much earlier. So colorectal cancer screening can either be based on stool-based testing with fecal occult FIT or fecal immunochemical testing, DNA FIT, or direct visualization tests, which are colonoscopies, CT colonography, flexible sigmoidoscopies, or a combination of the two. Screening recommendations in those with germline mutations are a little bit different, wherein we try to get them earlier. So patients with Lynch, you try to start at 20. Those with Peutz Jeghers, you try to start at 8. Familial adenomatous polyposis at 10. Juvenile polyposis at 12. Those with hereditary hemorrhagic telangiectasia really at the time of diagnosis or early as 6 months of life. Those with NUTYH associated polyposis at 20, and those with IBD would have probably already had a colonoscopy for diagnosis. But if they were to have some sort of severe dysplasia or colon cancer that was diagnosed, then they won't be candidates for near total or subtotal colectomy just because of the high incidence of both synchronous and metachronous cancers. So we take a look at signs and symptoms specific to the young. So most common presenting symptoms are really rectal bleeding. You can see them in about 50% of the cases that have presented. Other things are abdominal
No,
pain,
one bucket,
diarrhea,
please.
and iron deficiency anemia. I'm sorry. And iron deficiency anemia. Others would be like fatigue, malaise, nausea, vomiting, and constipation. So Fritz et al. Looked at how many risk factors that patients present and how much time it took for them to get diagnosed. So in patients who only had one symptom, it took about 9.7 months, two symptoms, 5.8 months, and those with more than three symptoms still took about 4.8 months to get diagnosed. But if you think about it, 5 months to get to a diagnosis when you're having rectal bleeding, abdominal pain, and diarrhea seems still a pretty long time. And a lot of it, I think, is like, so CRC in the young, they experience symptoms for much longer. There's also longer delay to diagnosis, obviously, when you compare it to older patients. A lot of it, I think, is related to lack of education from the patients and also lack of education from our part. They had done a survey wherein they had asked responders how long did it take them from the time they had symptom onset before they actually decided to seek medical attention. And 41% of them waited more than 6 months before actually seeking medical attention. And those that did, some of them were just diagnosed with hemorrhoids, irritable bowel syndrome, and just plain old anemia without further evaluation. A lot more early onset CRC patients also didn't have insurance at the time of diagnosis, or they had insurance with high copays that probably prevented them from coming earlier as well. A lot of them saw two or more physicians prior to getting to the diagnosis. 11% of them had more than four different doctors take a look at them before they got diagnosed. A significant number of patients felt that the doctors were dismissive of their symptoms. But unfortunately, 71% of them were diagnosed actually with stage 3 or stage 4 disease, so pretty advanced disease. So just to recap, a lot of early onset patients do present with symptoms. Duration of symptoms are much longer when you compare them to late onset. They tend to have a stronger family history, and we've seen that they have a stronger percentage of pathogenic germline mutations. Most of them have left-sided or rectal primaries compared to older onset. They do also have more aggressive pathology, wherein they can have mucinous, higher rates of mucinous, signet ring, and poorly differentiated disease. I'm sorry. All of which then results are correlated with poor prognosis. There are also some molecular differences that they found between early onset versus late onset. Early onset tend to have more microsatellite and chromosomally stable disease. In early onset CRC, you can see the one in blue is early onset, orange is later. So they have more TP53 mutations, CTN and B1 mutations, and then in later onset CRC, you can have more APC, KRAS, and BRAF mutations, and it kind of mirrors what we know already between right-sided and left-sided colon cancers, wherein right-sided colon cancers tend to have more BRAF, KRAS mutation, and MSI high disease, or Lynch syndrome tends to present more in right-sided. Those in left-sided cancers tend to have more TP53 mutations. So the question is, have we changed treatment really just based on a patient's age? So far, there's really no data to change treatment if you have early onset CRC. These patients, just because they have less comorbidities, they have better performance status, and you kind of feel that there probably has a longer time that is at stake, we tend to try to overtreat them. So the figure on the right, sorry, excuse me, has about a total, so they looked at about 43,000 rectal patients, 9,000 of which were younger than 50. They took a look at patients with rectal cancer stage in different stages. I'm just presenting the one with stage 1 disease. And they compared patient outcomes and patient survival, comparing those who were treated based on NCCN guidelines and those who were outside NCCN guidelines. Those who are outside NCCN guidelines tend to receive a lot more treatment. And if you take a look at it, there's a clear separation of the curves wherein those who were treated within NCCN guidelines had more benefit than those who did not. And then this one is just looking at colon cancers, shifting gears. Again, younger patients have less comorbidities, has possibly more aggressive pathology, higher stage. But when you take a look at how much post-operative chemotherapy they got, a lot more patients that were in the young population got chemotherapy. A lot of them, instead of having single agent regimens, had multiple agent regimens, and these were matched based on stage. And were followed with guidelines. So even though young patients had significantly more received more post-operative systemic therapy, had more multi-agent chemotherapies, has less comorbidities. When you compare them to the older population and the figure on the right, there's really not much of a difference between the two. So trying to overtreat and trying to give these patients a lot more aggressive treatment based on just the number of chemotherapy agents we give them and duration of which doesn't seem to have much of a difference. This is another study wherein they took a look at patients with stage 2 and stage 3 colorectal cancer out of the IDEA collaboration, which is basically about 6 trials all combined together. The background of this is that, again, same story, early onset CRC, had better performance status. They had similar T stages. They had higher number of nodal disease. These patients were more likely to have completed the planned treatment duration and also had received higher treatment doses and less dose interruptions. But when you take a look at their risk of recurrence, the one that is kind of like bluish green solid line are those with stage 3 T4 and 2 disease. So those would be your high risk stage 3. The ones in the dotted lines are high risk stage 3 that are are greater than 50. This is less than 50. And you can see that they had a lower recurrence-free rate. So meaning the younger patients had recurred much earlier than those of the older population. Same goes with stage 2. And the difference, you can't really see that much in high risk stage 2. Sorry, this is low risk stage 3, and then this is high risk stage 2. In terms of mortality, you kind of can see the same story wherein those with high risk stage 3 early onset tend to do worse than those with high risk stage 3 that's late onset. So even if you're able to give these patients better, even if you're able to give these patients a lot more treatment, it's just their biology from the get-go is much worse than the later onset population. So what about a metastatic disease? Same story. This is a study that included patients with metastatic disease on first-line chemotherapy and biologics. And really, there's not much differences in their overall survival as well as their progression-free survival from 35 to more than 50. It's about the same. If you take a look at those less than 35, you can see just by looking at the numbers themselves that there is a trend that they are doing worse. but there's also a whole lot less patients in this population than all the others. So it's really hard to say that, oh, if you're less than 35, you have worse disease and you're going to do a whole lot worse than others. There's also, so those are all the medical aspects of it. But there's also a very big importance that we need to put on the social aspects of the disease. If you imagine someone in their 30s or 40s getting a colorectal cancer diagnosis, it does have a little bit of a different perspective than those with late onset. You are essentially in the prime of your life wherein you're taking care of the young children that you have and also your aging parents. You are at a point wherein you're just starting a new job, possibly, or starting your career. Like me, I'm an early career physician. And then you get diagnosed with colorectal cancer. So a lot of these people, this is a survey that they had done on survivors and caregivers, and a lot of them had a lot of concerns about their mental health. A lot of them needed help for depression, panic, anxiety. A lot of them had shown withdrawals and like withdrew from other people in their lives. A lot of them experienced emotional exhaustion, felt financially stressed with just the diagnosis and also the ongoing treatments. There was a separate survey that I didn't include, but they actually also showed that a lot of these patients tend to have less understanding about treatment options and when they're faced with having to make healthcare decisions, because it's basically the first time they're getting diagnosed with any sort of disease and for probably the first time they're ever going to be in the hospital, they don't really feel confident in what their decision is. A lot of them reported really just the fatigue and lack of sleep and a lot of anxiety from all the treatments that they were getting, and also a lot of the decisions that they have to make from a day to day. And they don't know what symptoms to report to their physicians and which symptoms are just to be left alone. So this is the Delphi Initiative for Early Onset CRC. It's basically they had gathered about 69 experts from Europe and the US. They looked at systemic review of the literature and they were able to make evidence-based consensus recommendations on 7 key areas relevant to clinical management. So that includes diagnosis, risk factors, genetics, patho-oncology, therapy, endoscopy, and supportive care. Diagnosis, again, hematochezia, iron deficiency anemia, unexplained weight loss. Ideally, you would get a colonoscopy within 30 days. Risk factors or heightened recognition of risk factors such as family history, inherited cancer syndromes, IBD, genetics. All patients should have multi-gene panel testing for germline genetics. At the same time, they should also get tumor genomics. At least, the very least, they should get MMR or MSI testing. KRAS, NRAS, BRAF, HER2, and NTRK mutations give us some prognostic information as well as therapeutic options later down the road in the metastatic setting. There's no indication at this time to intensify adjuvant, neoadjuvant, or systemic therapies based on age alone. There's no need for extended surgery just based on age alone as well. All these patients should receive fertility information. These are an option to talk to a reproductive specialist. We should be more worried and continue post-treatment surveillance at least every 5 years, even after they've done their routine screenings. And then a big focus really on supportive care, discussing sexual health, dysfunction, mental health, early access to physical activity and nutritional programs, and enhanced supportive medications as they undergo treatment. So a couple months ago, we launched a young onset colorectal cancer program at the BCC. This is really a compilation of all the services that we have from a medical standpoint and a social standpoint to help out patients that are getting diagnosed in such a young age. When I started my own practice, in my first month, I actually had 4 patients who were less than 50, and a lot of their questions kind of circled around family. wherein how do you talk to patients about a cancer diagnosis? What do I tell my boss that I have to undergo treatment? What do I do? I am the primary breadwinner in my family, and then some of them had trips planned for Disneyland should I cancel it as I undergo cancer treatment. So I recently saw that they had posted on the UofL website a article by Kim Williams, who's one of our wonderful social workers, on how to talk to children about a cancer diagnosis. And she actually breaks it down depending on patient age. So the young onset CRC includes medical services wherein you get multidisciplinary care from the surgeons, med-onc, rad-onc, pathology, and radiology. And really more so, this is in the form of our tumor boards. You can get genetic counseling and pre-testing counseling. And when I talked to Meredith, who's our genetics nurse practitioner, a lot of patients actually are coming in based on self-referral. So if you think that you yourself have risk factors or a strong family history and want to have genetics done, she can help you with that. It's just via the whole hotline. We'll refer patients for oncofertility. We can help out with colonoscopy screenings. There's a sexual health program called the Grow Clinic, which helps out with urinary incontinence and also erectile dysfunction issues. You'll get access to clinical trials. The Thrive Clinic, which is a survivorship clinic with our nurse practitioner and also Dr. Nelson, who's our PMNR, attending. You also will get a lot of wellness programs. So massage therapy and acupuncture are things that actually our patients have really enjoyed. Music therapy, art therapy will give you resources to help out with support groups, just having to talk to someone outside of the family wherein you don't really have any sort of responsibility to seems to be helping out a whole lot of our young patients. And you can kind of see what their demeanor and outlook have changed just depending on how they are in their course of treatment and after they've talked to someone about their struggles as well. So that kind of concludes a large part of the CRC. We'll talk about esophageal, gastric, and pancreatic biliary in the next few slides. There are also some somatic differences in esophageal cancer that they've seen in the young. So BCL2, CASP8, NOS3, TNFRSF10A can contribute to early onset. Clinically, there's not much changes that we have done in treating esophageal cancer as well in the young population. We know of some risk factors such as family history, high-risk germline mutations, HPV infection, smoking, alcohol use, GERD, evidence of Barrett's disease, obesity. A lot of these patients too have a greater depth of invasion, so higher stages, a higher likelihood of lymphatic spread or nodal disease at the time of diagnosis. They do also have a higher stage. So by the time they got diagnosed, 37% versus 23% have already been spread to different areas or distant sites of metastases. So overall treatment paradigms haven't really changed, but patients were more likely to receive neoadjuvant or adjuvant therapy than their average age or later onset counterparts. Survival, though, hasn't really much changed between the two subsets, about 15.2 months, not really much has changed. Gastric cancer is the one that's really rising more in GI cancers. There's a strong association with H. pylori and EBV infection, but really there's no indication for gastric cancer screening in these patients right now, just based on the fact that they've had these infections. Risk factors are very similar: tobacco use, alcohol, higher intake of beef or barbecued soft foods, smoked foods, and lower intake of fresh fruits and vegetables. Currently, we only do screening for patients with history of gastric adenomas if they have high-risk genetic syndromes such as Lynch, CDH1, or hereditary diffuse gastric cancer, Peutz-Jeghers, or familial ptosis, polyposis. Those are the ones that we would do gastric cancer screening for. Patients with pernicious anemia. And in those some in high-risk countries, once I think you turn either 40 or 50, then they have universal screening for gastric cancer just because of the increased prevalence or incidence in their country. There's also some somatic differences too. They're less likely to have microsatellite instability disease rather than late onset. They have a higher proportion of RHOA mutations and Claudin 18 ARH GAP fusions. Same story, more likely to present with multifocal disease, higher tumor grade, and worse in histologies with poorly differentiated diffuse histology and signet ring histology. Survival differences are between the two, early onset versus average age onset. There's really not much of a difference still. Going into pancreatic cancer. Looking at, so they had this, I think, had about 330 patients that they had compared between early onset and average onset. And they saw that those who are early onset tend to be more current smokers. They had better performance status, had higher CD19-9 levels at time of diagnosis, had higher albumin levels, had higher, interestingly enough, second degree relatives with pancreatic cancer or family history of cancer, and less more so diabetes than their average onset pancreatic cancer. They do also have a higher prevalence of germline mutations similar to CRC. And the type of pathogenic germline mutations that they can find. So in average onset pancreatic cancer, mostly you would see like a BRCA1 or a BRCA2 mutation. Those with early onset, you kind of have more of a mixed bag. You have BRCA1, BRCA2, PALB2, MSH2, PMS2, which are your Lynch, STK, and TP53. And when they compare the patients with pathogenic germline mutations, they actually overall did better than those who didn't, probably because you had additional lines of therapy. And same goes like if you break it down between early onset and average age onset, that you would still do better if you had pathogenic germline mutations. Early onset patients has more KRAS wild type tumors, have more targetable mutations, so then they would get more targeted therapies like olaparib, pembrolizumab, tacilizumab, which is a PIK3CA, which I don't know if this is approved at this time frame. They tend to have more triplet regimens than doublet chemotherapy regimens, modified FOLFIRINOX versus gemcitabine and Abraxane, and they tend to get more lines of therapy with a median of 2 versus 1. Survival outcomes in general with all, they have pretty similar. So early onset's about 18.7, average onset 17.6 months. If you break it down to those who are just metastatic, maybe they have a longer overall survival, but there's really not a very long difference. Same goes with progression-free survival. It's only about a 1.8-month difference. Screening guidelines according to AGA are those with high-risk germline mutations. So we've kind of talked about Pete's Jeghers, hereditary pancreatitis, those with CDKN2A gene mutations, Lynch syndrome, BRCA, PALB2, and ATM gene. First-line relatives of patients with pancreatic cancer, especially if the first-line pancreatic cancer patient has never been tested for pancreatic cancer germline genetics, that would be an indication. For genetic testing, pancreatic cancer screening right now is in the form of MRI, MRCP, and EUS. If you have high-risk individuals, those with CDK2A, PRSS1 mutations, and Pete's Jeghers, we tend to do it much earlier at 35 and 40. But if you just have this one, then we start to do it at 50, and we do it annually. Looking at biliary cancers, this is just a baseline characteristics table. Those with younger onset tend to have more primary sclerosing cholangitis. Those who are older tend to have more diabetes and have a higher BMI. There's really not much changes between the sex, the race, and also the location of the cholangiocarcinoma or biliary cancer. When you take a look at the post-operative pathology in those with localized disease, they tend to have a larger median tumor size. So these tumors are much larger and they tend to have more nodal involvement. There are also some molecular differences with biliary cancer. These patients tend to have more FGFR2 fusions, ATM and BRAF mutations than their older onset counterparts. And among those who do end up getting surgical resection, there's a lot more patients that were younger that tend to get more systemic adjuvant treatment rather than those who are older. They, again, same story. They had more combination chemotherapy compared to those that are older. The lines of systemic therapy too, they're able to tolerate a whole lot more. So they were able to get 2 or more lines, and there's a larger proportion of them who do try to go for clinical trials. And because they have more FGFR2 fusions, then they would receive more targeted therapy than the older patients. You can see here that maybe there is some differences in their median overall survival, 17 months versus 13.5 months. This is when they broke it down to those with localized and metastatic disease. Those with localized disease didn't really have much of a difference. The trends were better in those who got palliative systemic treatment or those with advanced disease, 19 versus 14.9 months, even though it wasn't really statistically significant, but the trend was there. So just as a summary, early onset GI cancers are rising in incidence. CRC is now the leading cause of cancer-related mortality in men and second in women. CRC is only really just the tip of the iceberg. That's where a lot of the studies and data have been surfacing right now, but we can also see from pancreatic biliary and also gastric cancer that those are all increasing. Causative factors are being studied, but still overall unknown. We do know a little bit about the risk factors, but it's so hard to say that I was exposed to this at this age, and this is what happened, and that's why I'm at a higher risk. Younger patients have a higher proportion of germline alterations. However, majority would still be sporadic. Some somatic differences also exist, and they present with more aggressive pathology, higher stage at the time of diagnosis, and overall poorer prognosis, it seems like. So there really is a need for germline genetic testing and tumor genomic profiling, so we get a better idea if they have additional treatments or that we can offer. I would urge everyone to have increased awareness from both the patient standpoint and also the clinician standpoint to diagnose these cancers earlier. And these patients should be treated by a dedicated multidisciplinary team, not just from the clinical standpoint, but also to address a lot of the unique challenges in this population. So I think that is my last slide. I appreciate everyone's time. If you have any questions, feel free to ask them, or I will ask Jason what to do next.
Well, thank you so much, Dr. Chan. Really appreciate all of the insights that you've shared with us this morning. This is certainly, for those of us who are not in the area, kind of a shock that we've been screening people at 50, and we probably should go earlier, as you said, down to 45, but maybe it should be earlier. So that would actually be my first question. How long does it take to take this data in a New England Journal of Medicine article that you quoted was 2022? How long does it get to change the guidelines and then change practice? And should we, second part of that same question is, should we be going less than 45 for our screening for colorectal cancer?
I mean, from 50 to 45 is also already a big jump. It's really hard to to also say, okay, we should just screen everyone at 35 just because the risk is increasing. And that would put a whole lot of strain in our medical system. You just imagine it's so hard to get people into GI and colorectal surgery to get colon cancer screenings now. So to try and get them to a younger stage, that might just have a lot of impact and strain on our medical system. So I don't know if we're ready for that yet. And really, maybe it's more of trying to determine what risk factors that we can identify, maybe get a risk scoring system that we can use and validate that if you have A, B, and C risk factors, then you would qualify for much earlier. And if you don't, then we'll see kind of just have it done at 45. At the same time, maybe just using more of the non-invasive testing. So like people will call it fit testing, might be the way to go. But right now, going from 50 to 45 took such a long time. I imagine it will just be much harder to get it down to a lower age.
All right. We do have a time for just maybe one or two quick questions. I don't know if I know, and so if you would like to, you could unmute and ask, or if you want to post something in the chat area, we can pass it on to Dr. Chan. So
if there's not a second question, I'll go ahead.
okay.
So you talk about the genetic markers, and their germline issues. That says that maybe what you're sort of a follow-up of your first answer is, should we start doing genetic testing at an earlier stage? Now, obviously, these are genetic markers predominantly after a person has been diagnosed. Should we be using some of them for screening?
So, I mean, I think there are a lot of people who are looking into that doing blood-based screening for colon cancers and pancreatic cancers. There's been a lot of research going into that. So I think that will be something worthy to look at and I think there's just not a lot of patients get genetic screening done. Even if they have a strong family history, I don't think they have the knowledge that, hey, that you should get the screening done. I've had some patients that actually went through the route of, is it 23andMe, the commercial testing? And then that's how they found out that they had some germline genetic testing abnormalities. And they were like, can you confirm that with an actual test that we do? And I've had patients where their parents have Lynch syndrome, and they came to me as a 37-year-old. I think he was 37, as a 37-year-old with metastatic disease and found to have Lynch syndrome himself. So it's kind of like, well, if your mom and dad have Lynch syndrome, it's also safe to say that you should get tested yourself once you're of age. So I think there's some resources that we already have. It's just underutilized at this point. It's just a matter of we just don't know that these services exist.
Sounds like a good time for a public service announcement and education, because this is alarming rates of increase.
Yeah,
Right.
I agree.
Jason, I don't see any more questions in the chat.
Yeah, nothing new. So I think we can wrap it here. So Dr. Williams, if you want to do a quick outro, and we'll wrap it up and head on to Cardinal Minute.
Well, fantastic. I thank you very much, Dr. Chan. This was really insightful and hopefully game-changing for so many people as we try to adjust to the changing pattern of these particular cancers. And so I'd like to thank everyone for your attendance this year, and make sure everybody knows that they are available on ViewMedi. We are now viewed around the world by lots of people, according to ViewMedi, and so we're looking forward to restarting in the fall. And please also join us next week, if you will, for our awards ceremony, and that will be the official end of Grand Rounds. This one is the last educational one. The next one is one where we just celebrate all the accomplishments of all of our trainees and faculty. And with that, that'll end the grand rounds for today.
All right.
Thanks so much.
Just two really quick things. Awards Day is going to be in person this year for the first time in a few years. It'll be in the ACB auditorium. We'll have some refreshments. So we'll hope you join there. And also, Dr. Williams, don't forget, we have research grand rounds today at noon. Lunch is provided. Dr. Bhatnagar is speaking, and so it'll be another great session. So we hope to see as many, and you can, and folks, if you can't get there in person, you can join it here actually at the same link that we use for the medicine grand rounds. So that's at noon today. So looking forward to seeing some folks there today too.
Absolutely. And so really want to thank Dr. Bhatnagar and Dr. Boley for doing it last week. And we've already had a large amount of uptake, and we're really looking forward to having the research grand rounds really become part of what we do and spread the fantastic things that our research enterprise is accomplishing. And as it turns out, we will continue research grand rounds every Thursday at noon with food in person on ACB 3 at conference room. And we'll do that throughout the summer without a break.
All right. Thanks, Dr. Williams. Thank you, Dr. Chan. And I know she had to go to clinic, but thank you to Dr. Riley too for helping facilitate and everything. And we really appreciate it. So thanks everyone. And we'll, as far as medicine grand rounds, we'll see you next year in September. As I mentioned, Dr. Williams is on the clock for his opening talk on September 5th. So Dr. Chan, thank you so much again. We really appreciate it. And okay, we'll stop there.